Hello, everyone. Welcome to the first episode of Not So Nerdy Actuary.
What? Bro, what are you talking about, man?
This episode and this series is all about you. It's about learning from the experiences of people from different geographies, from different domains, and people with different experiences in life. It's about learning from their career arc and understanding their learnings and not repeating the mistakes which they might or might not have committed. So I'm Harsh. I'm a part qualified actuary at Q3 Insurance. And I have with me today Nidhi. Over to you, Nidhi.
Hi everyone, I'm Nidhi and I'm a nearly qualified actuary and working as an international actuarial consultant with Willis Towers Watson. So today our first special guest is Scott Fry, who is health actuary at Care Oregon. Hi Scott, thanks for joining. Happy to have you here. I'm sure you would have great insights and experiences to share with us, and we both, part qualified and nearly qualified actuaries, are eager to hear from a fully qualified actuary his side of story. But before that, could you please tell us a bit about yourself?
Sure. I've worked as a health actuary for about 10 years now. Just in the last year, I've become a manager. So I do a lot of individual work, but I also have an actuarial analyst that I work with that we hired. Um, I've actually only met her in person one time because we have been remote working from home this entire time. So we got a chance to meet and hang out distance a while ago, but it's been a while. So it's been a really interesting transition to being a manager. And I live in Portland, Oregon in the Northwest United States.
It's good to have someone from the US healthcare system. So, what made you pursue an actuarial career? And what sort of challenges did you face while you were in the journey of your actuarial career?
I was originally in an economics PhD program. From when I was in high school, I loved economics and just wanted to study it and be a professor. Once I actually finished my undergraduate degree and was in a PhD program, I realized that it's a lot of research by yourself and not a lot of interaction with other people. That was something I really missed. So I was able to finish a master's degree and kind of was looking for, well, what do I do with this? What other options do I have? And I had never heard of, maybe had heard of actuarial science, but didn't really know it was an option, and just Googled, what can you do with an actuarial or with an economics degree, and found that it seemed like a perfect fit because it's a lot of the things that I like about economics. There was a big focus on probability. A lot of people hate actuarial tests, but I'm okay, pretty good at doing standardized tests. So I was like, wait, this might be an in for me. And I kind of started studying for exam P on the side when I was first starting out, and while working another job. And once I passed it, I was looking for a job. So that was really exciting and what I got into. I've worked at a number of different locations. So I started actually at Willis Towers Watson when they were Towers Watson in Phoenix, Arizona. So I was surprised. They're all over the place. But then I moved to Portland about 7 years ago, and I've been working there for a Blue Cross Blue Shield plan, which is primarily employer insurance and some of the Affordable Care Act marketplace. I worked for a really small independent consultant, so like 25 people in the whole company. And then I went back to Willis Towers Watson, actually, which is like I don't know, 20,000 people company. So big transitions. And right now I'm at Care Oregon, which is a Medicaid provider. Medicaid, if folks aren't familiar, is the insurance program for low-income folks in the United States.
I mean, it's interesting to know that we all started our careers from Willis Towers Watson. So, I mean, how does your typical work day or week look like?
So work days today have been far but typical, but honestly, the big difference is just whether I'm at my house or whether I'm at the office. So that hasn't been a big change. The biggest change has been communication, right? So how do we talk to people? How do I meet with my analyst on a regular basis and stay in touch? She can't come over and I can't come look at her screen and help her with an Excel formula. So that's been a big difference. But my day tends to be, I realized a lot more meetings once you're a manager. And so it's a mix of kind of individual work for probably 3 or 4 hours a day, probably three hours a day of meetings, and then the rest of it is spent with my analyst, interacting, reviewing her work, giving her updates and checking in on a regular basis. So it's really shifted from, as a new actuary, really like 6 or 7 hours a day, not very many meetings, to 6 or 7 hours of just pure individual work, to a lot more collaboration with teams and a lot more just informing people about my work, them having requests and then giving some insight and advice, rather than constantly kind of producing analyses, which feels like what you do with, at least with my experience as a new actuary.
Could you please throw some light on the US healthcare system and the challenges it faced from an actuarial perspective, specifically in the view of COVID-19?
COVID-19 has had a really disparate impact on different parts. So at the beginning of the pandemic, the biggest issue, well, from one perspective, was not that too many people were using the hospitals or doctors' offices, but that too few were. So there were big pay cuts at some hospital systems, and also a lot of smaller providers, doctors that are working by themselves, either went bankrupt or decided to kind of retire if they were towards the end of their practices because they were having such revenue issues. One thing we actually did at Care Oregon was, because we had the opposite issue, that we had fewer things to pay for, we did a provider stabilization payment. So we went out to our behavioral health providers and our primary care providers and kind of looked at how much revenue they had missed in that period from March to June, where everyone was really, they were still transitioning to telehealth. There weren't a lot of people that were able to see folks, and we made a payment to them to kind of keep them solvent, because we were really worried about our network, which is mostly safety net providers, so folks with less financial capital, and we made a kind of supportive payments to them. Other big differences have been, we have a number of risk sharing models. So where you and a provider, primary care provider group, are at shared risk. So if there's gains, they share in some of the upside, and if there's losses, they share in some of the downside. And that has been something we've really had to look at. So the biggest impact for us has been setting the targets for 2021. Usually we would use the previous year and use 2020 data for that. Obviously, the utilization patterns have been totally different. And so in most cases, we've gone back to 2019 and used 2 years of trend, but that's really thrown off a lot of our processes. We've also had to look at exclusions. So in the United States, the federal government is buying all of the vaccines themselves, so the actual the actual vials of vaccine, but payers are still required to pay for the administration fees. So we're excluding those from our risk share agreements, because even at only about $20 per injection, that across every single member, that would have a pretty large impact, and we are getting compensated by the state. So it's added some complexity in both how we set our targets for those and how we actually, what we include and exclude. We've been fortunate in Oregon that we have seen some of the lower rates of actual infection and hospitalization in the United States. So we haven't seen as much of an impact on our population of the costs of testing or actual hospitalizations. The biggest impact has actually been that opposite, that ER volumes are really low still. Hospitalizations are still quite low from the baseline. And we've done a ton of work internally to track, we track ER and hospital utilizations using kind of some systems that note when a patient comes into the hospital. So on a monthly basis, we actually look at that. So instead of waiting for 2 or 3 months of run out, we see that data on a more frequent basis and can track whether people are using the ER or the hospital. The other piece that we've done is one of our analysts has put together a lot of COVID tracking worksheets. So he's able to track any time that someone has a COVID diagnosis on a claim, actually track at the patient level the administration of the vaccine and whether someone's had their first vaccine or their second vaccine, because those come through coded differently. So it's been a ton of upset to our work, just a refocus on COVID-19 topics. The last thing I'll touch on is, as a Medicaid provider, the government paused redetermination, which is a process by which people that are eligible for the program, every 12 months, they look at those people and see if they still qualify. That process has been paused, and a lot of people have lost their jobs, unfortunately, and that's added a huge number of members onto Medicaid. So right now we've seen a huge swell in the number of members on Medicaid. That may change, that we're expecting that to go back down in 2021 and 2022 as some of the economic results dissipate and as redetermination gets turned back on once some of the pandemic crisis passes.
Thank you for the insights. So with respect to the data, what do you think the data which you have collected in 2020, specifically with respect to healthcare, will it be an outlier, or do you think the data preceding 2020, which is the data up to 2019, will that become an outlier and redundant? So what do you think? How would you treat the data, specifically the data which we collected in 2020?
We were initially thinking 2021 is going to be this return to normal. Obviously, that's really not been the case yet, although we're on our way, but it's still looking like suppressed utilization. Most stuff is closed or at least limited capacity. That makes me think that 2020 data you probably can't use on an unadjusted basis, because for those 3 months, especially in March and April here in the US, like everything was closed. Like UC physician visits dropped to 50%. I don't think that's reflective of a longer term trend. What I do think you can get from 2020 is information about telehealth and transitions that may be long-term to some of the ER utilization questions, so emergency room use. I think there are nuggets in there that you can pick up from 2020, but I think it really is going to be a tough work for actuaries to use 2019 as kind of baseline data, but informed by some of the trends we're seeing in 2020 and 2021. Because I don't think personally that all of these trends to telehealth are going to go away. I think the proportion will go back down, but I think we're going to be higher than we were in 2019, kind of on a permanent basis.
Thanks for this. So last but not the least, based on your accumulated experience so far, what advice would you like to give to your younger self?
Great question. I think to me, the advice that I would give would be not to change the focus on exams, because I think passing those really has to be core to the actuary's job. But I was always under the assumption that the best actuary is the one with the best technical skills, the one that can do the analysis the fastest, that is the most clever. And I've really come around, even though people told me at the time it was hard to take it seriously, that like the ability to communicate clearly, and especially so much of my day is explaining to non-actuarial and often non-finance folks what the actuarial implications are. So we work a lot with clinical folks, with people in our quality team, and being able to understand and kind of have that discussion with them is really important. And so like what is rare for an actuary is to build up both their communication skills and their technical skills. I think it's that intersection that makes our work valuable. And that's what I would kind of emphasize. So I was so focused on like, you have to get the technical skills down. That's entry into the profession. But the people that I see succeed and move forward the fastest are those that are really good at communicating their work, not just at doing the actuarial kind of calculations and assumptions.
We totally agree with you, Scott. It's really important to have a good balance of communication and technical skills to be a good actuary. Once again, thank you for your time and sharing your wonderful insights and experiences with us. Much appreciated. Thank you guys for watching our first episode of Not So Nerdy Actually. And if you want us to come back with more such videos, then please like, share, and subscribe our channel. And we'll see you soon.
Thank you, Nidhi. Thank you, Scott. See you soon.